Hello dear viewers, in this video which is part 7 of continuous renal replacement therapy, I will be discussing part 1 of renal citrate anticoagulation where I will discuss an overview of renal citrate anticoagulation during continuous renal replacement therapy. What is renal citrate anticoagulation and how it is performed? What are the advantages and disadvantages of renal citrate anticoagulation? As the name suggests, it is renal, means it is restricted to extracorporeal circuit. Renal citrate anticoagulation is a method used to prevent blood clotting in extracorporeal circuit during continuous renal replacement therapy. It involves infusing citrate into circuit which binds to calcium, an essential factor in the clotting cascade, thus inhibiting coagulation. To counteract the calcium chelating effect of citrate and prevent hypocalcemia, calcium is infused back into the circuit before it returns to the patient. There are a number of steps involved in this process. Initially, citrate is infused into the blood at the beginning of extracorporeal circuit before the blood enters hemofilter. Citrate binds to calcium ion in the blood and forms calcium citrate complex. It means calcium is effectively removed from the blood, hence not able to participate in the coagulation cascade and prevent blood from clotting within the extracorporeal circuit. A significant portion of the calcium citrate complex is filtered through the membrane and goes in effluent, and remaining calcium citrate complex returns to the patient. To prevent hypocalcemia, calcium is infused back into the circuit, usually after the blood has passed through the filter and before it returns to the patient. To monitor target ionized calcium levels in the circuit to exert optimum anticoagulant effect, sampling is done post-filter while venous or arterial sample is taken from the patient to monitor patient's ionized and total calcium level. Target circuit ionized calcium level to prevent clotting is 0.20 to 0.4 millimole per liter, but the target value should be individually adjusted according to the treatment situation. No systemic anticoagulation means no anticoagulation in patient occurs due to citrate, as citrate calcium complex crosses hemofilter membrane and the loss through this route depends on ultrafiltrate volume. The remaining citrate or citrate calcium complex that present in venous line and is delivered to the patient is diluted in blood and rapidly metabolized by liver, kidney and muscles to form bicarbonate. One citrate molecule forms 3 bicarbonate ions, and during metabolism calcium is liberated, which helps to normalize calcium levels. Calcium ions is also infused systemically to keep ionized calcium at lower normal levels, and that is serum ionized calcium 0.9 to 1.1 millimole per liter. While delivering continuous renal replacement therapy using renal citrate anticoagulation, the filtered calcium level should be closely monitored during the first 24 hours of treatment. It is usually measured with a blood gas analyzer. It is recommended to conduct the first detection 30 minutes after the start of treatment and then monitor ionized calcium every 2 hourly for 4 consecutive times. Adjust the flow of citrate according to the level of ionized calcium in the filter and then monitor every 4 hourly for 4 consecutive times after it is deemed stable. If the treatment goes well, monitoring can be changed to once every 6 hourly after 24 hours. There are mainly 3 types of citrate solutions available for this purpose: 4% trisodium citrate, acid citrate dextrose solution, and citrate containing replacement solution. The first two are hypertonic solutions and are often used with the calcium-free or reduced calcium dialysate solutions. Citrate containing replacement solutions are prismocitrate. These are isotonic to plasma and can be used as both anticoagulant and replacement fluid. It is important to understand that prismocitrate can be given as pre-dilution replacement fluid and it cannot be used for post-dilution or dialysis. Why one should use regional citrate anticoagulation over heparin? So in terms of advantages of regional citrate anticoagulation, there is reduced bleeding risk compared to systemic heparin anticoagulation, particularly in critically ill patients. It extends the lifespan of filter in CRRT by reducing the frequency of filter change due to clotting. A longer filter lifespan and fewer treatment interruptions means more efficient CRRT delivery. As there is no heparin, there is no risk of heparin-induced thrombocytopenia. Additionally, some studies suggest that regional citrate anticoagulation may be more cost-effective due to reduced filter replacement. The side effects of regional citrate anticoagulation include metabolic alkalosis, as citrate metabolism can lead to production of bicarbonate, which can cause metabolic alkalosis. Moreover, in critically ill patients with hypoxia or hypoperfusion, citrate accumulation can occur, leading to ionized hypocalcemia and metabolic acidosis. When trisodium citrate used, increased sodium load to patient can cause hypernatremia. Hypomagnesemia can occur from binding to citrate calcium complex. While patient is on regional citrate anticoagulation during CRRT therapy, the careful monitoring of ionized calcium in both the extracorporeal circuit and the patient is crucial to ensure adequate anticoagulation and prevent complications. Patient's pH, total calcium and serum sodium monitoring may also be required. In terms of contraindication of this therapy, there are no absolute contraindication to using regional citrate anticoagulation. Shock, severe liver dysfunction, or hyperlactatemia should not be considered as absolute contraindication to regional citrate anticoagulation. These patients should be considered as belonging to a higher risk group that should be monitored closely during treatment. Here I finish. Do you consider this information is relevant and important to your practice? If so, please provide your feedback and do not forget to subscribe to this channel. If you have any questions, please write them down in comment section. See you in my next video on CRRT part 8 and renal anticoagulation part 2. Till then, bye and take care.